Good evening. At the outset, I would like to thank the organizers for having given me this opportunity to conduct this part of the program. I also feel honored because the panel contains my teacher, who apart from being one of the most accomplished researchers, was one of the finest teachers of our time, Professor M.S. Kuru. So, I will go straight to business. Pregnancy is a beautiful time in a woman's life, but it can be at times most stressful, both for her as well as her gynecologist. 18 to 35% of pregnant females in USA are obese, and obesity has adverse maternal and fetal outcomes. So my first question goes to Professor Farad. What are the metabolic complications of pregnancy? Farad.
We have few metabolic diseases and complications which we commonly come across during pregnancy. And one of the commonest, which we are seeing now, is maternal obesity. Then we are seeing diabetes in the form of gestational diabetes mellitus and diabetes as such, pre-gestational diabetes, and polycystic ovarian syndrome. They are all rising and the incidence is increasing tremendously. There was a time when we would crave for getting a diabetic patient in the labor room. Now we have almost 10-20 patients with diabetes in labor room. These are the most commonly come across metabolic syndromes we see in pregnancy. And then the complications which are associated with it regarding the mother, the complications like preeclampsia, pregnancy-induced hypertension, then effect on the baby, leading to growth retardation, abortions, and IUDs. They are very common, and then the cardiovascular problems which are associated with these metabolic syndromes.
Thank you. Non-communicable diseases have overtaken communicable diseases as the leading cause of death, sir. As per 2018 health statistics issued by WHO, non-communicable diseases were responsible for 71% of all deaths worldwide. And non-communicable diseases include cardiovascular disease, cancer, chronic respiratory illnesses, and diabetes. Now, diabetes is an important component of these non-communicable diseases, and its prevalence has doubled from 1980 to the current prevalence of what WHO says is 8.4%, though other figures are also from IDF. And diabetes can virtually affect any organ system of the body, and the involvement will depend both on the duration of diabetes and quality of control. My next question goes to Professor Kuru. What are the GIT complications of diabetes? And number two, are diabetics prone to any malignancies?
Thank you. Diabetes involves both GI tract and hepatobiliary system. It can just start from the beginning up to the end. Cricopharyx, your cricopharyngeal dysphagia, even abnormal, if you have hemoglobin A1C, particularly type 2 diabetes going wrong. Esophageal disorders like dysphagia. Very important is gastric problems, particularly peristalsis in the stomach, and gastric dilatation, coming with vomiting. Then small bowel and colon also gets involved, particularly in neuropathies. And you can have nocturnal diarrhea, you can have constipation. And so basically it's an involvement of diabetic neuropathy right from cricopharynx, esophagus, stomach, and bowel. And the manifestations can be varied. Now, as far as the liver is concerned, I think it's taking really the most important part, because non-alcoholic fatty liver disease and diabetes has become a major problem. And this, particularly if you have uncontrolled diabetes, these people are more prone to NASH, and they're more prone to cirrhosis. And so this is becoming a big problem, that diabetes and benign non-alcoholic fatty disease going to NASH and cirrhosis. And so this is really on the rise. This is one disease probably which is really on the rise. It also can cause higher incidence of liver cancers, particularly through NASH, cirrhosis, and hepatocellular cancer. Gallbladder diseases, gallstones, and maybe gallbladder atresia, particularly in patients who have uncontrolled diabetes. So the phenomena is very wide, and the spectrum is very large. It's only important that if you have a clinical condition to look that somebody has, particularly a type 2 uncontrolled diabetes, that becomes a bigger problem because longer duration, they come with GI manifestations much more.
What about type 1 diabetes? Are they more prone to pancreatic disease?
They also are prone to diseases. No, you might have diabetes secondary to pancreatic disease. That's completely a different thing. Particularly, that's the type of diabetes like chronic gastric pancreatitis or chronic pancreatitis can cause diabetes. I didn't want to put on that. But type 1 diabetes also can cause all these manifestations, but it's much more common in type 2 diabetes, these manifestations.
One more question for you, sir. How should we manage diabetic gastroparesis?
Now, gastric akinesia and gastric paresis, secondary to autonomic neuropathy, diabetic neuropathy, can be a big problem because you get gastric stasis, and these people come with postprandial distension. They come, the food doesn't leave the stomach, and they can come as vomiting. And it can be an intractable thing. One of them is to give a prokinetics. So if you start any of the prokinetics which are in the market and increase the dosage, many of them will do well, and also associated with that, you have to control the diabetes, get a hemoglobin A1C to some respectable level over a period of time. But many patients at least do respond to prokinetics. And if you change the combination, increase the dose, maybe to give sometimes combinations of one with another. So you may have other options. One is to have a surgical option, it becomes intractable, and second is an endoscopic option. Now, some patients can be benefited by pyloric dilatation. There are some recent reports that you can cause by balloon dilatation the pylorus along with prokinetics. Some people might do well. So that's why some people may need surgery, but recently pyloric balloon dilatation has been started as one of the ways of treating people who are intractable.
There's an announcement, there's a vehicle JK01AB9331. It needs to be parked properly. Obesity is one of the greatest healthcare problems in the world. The prevalence of obesity has trebled since 1980. At present, as per the latest WHO health statistics, 39% of world population is overweight and 13% are obese. This is the whole adult population. In India, the prevalence of obesity is 19.7%. And although the health consequences of obesity are well known, recently a concept of metabolically healthy obesity, where the person is obese but otherwise metabolically healthy, and they share the same cardiovascular mortality as those who are normal weight. So my next question will go out to our panelist, Dr. Mirajuddin. What are the cardiovascular complications of obesity? One. Number two, do you believe that a metabolically healthy obesity exists?
Thank you, Dr. Obesity, of course, is becoming an epidemic throughout the world. It is not only in the West, but in our place in Southeast Asia also we have seen in our area also we see a lot of the young children also developing obesity. Now this is becoming an epidemic. Obesity is a strong risk factor for cardiovascular diseases. And usually it is associated with other risk factors like hypertension, dyslipidemias, and that also adds to this risk of cardiovascular disease in these patients. So what you are saying about, there are two misconceptions about obesity. One is what we have been told, that there is one obesity, that is what we call as normal weight obesity. In normal weight obesity, we see that patient has the high risk for developing a problem. And what is normal weight obesity? They have normal BMI, but they are still having this risk which are related to obesity. That what we have seen is that there is truncal obesity in these patients, usually seen in Southeast Asia. Then what you say about this obesity without who don't have risk factors? That is the different obesity. Truncal obesity, the different other type of obesity is obesity around the hips and this arms and legs and extremities. They are obese. If we calculate their BMI, they are obese, but the risk is low. It has been found that they are not high risk for developing cardiovascular disease.
No, it's not normal weight. All these parameters, that their LDL cholesterol is high, triglycerides are low, their sugars are low, their insulin sensitivity indices are normal. So metabolically, they are very healthy.
They are.
They think that they have
BMI is high. BMI is high in these patients, but they don't have high risk for developing these complications of obesity. They have what was previously said to be pear-shaped or this apple-shaped obesity. That is supposed to be.
Professor Farad. In pregnancy, around 5 to 14% of pregnancies are complicated by hypertension. How do you manage patients who are detected as hypertensive in pregnancy?
Hypertension in pregnancy, it can be either pregnancy-induced hypertension, what we call, or it can be a chronic hypertension. So it depends upon the type of hypertension, whether it is superimposed or it's just gestational hypertension. The outcome of the pregnancy depends upon that. If a patient has chronic hypertension and then she has end organ damage, the management is a little different as compared to patients who develop gestational hypertension. Gestational hypertension usually develops in the later part of the pregnancy, whereas chronic hypertension, if uncontrolled, we are not worried. If it is superimposed by pregnancy-induced hypertension or preeclampsia, the prognosis worsens. So how do we manage these patients is early detection. If it is pregnancy-induced hypertension, it depends upon the gestational age, it depends upon the severity, and the associated complications which are associated with it. So if this hypertension develops in the later part of the pregnancy, our aim is ideally to carry this pregnancy to a stage where we can deliver a baby. That's the ultimate treatment for these patients. But we want to carry it to the stage where we can deliver a healthy baby. And our aim is to carry it in our scenario here up to 37 weeks, but outside they carry it up to 34 weeks. If it develops around that period, our job becomes easier. We try to control their blood pressure depending upon the severity. In mild hypertension, mild PIH, we need not to give them antihypertensives. We just monitor them and try to carry it up to 37 weeks unless there are untoward signs and symptoms which develop and label her as severe preeclampsia, where irrespective of the gestational age, we have to terminate the pregnancy. That's one. Second, if they are pregnant, just gestational hypertension, they have to be monitored and they have to be delivered in a center where we have facilities, tertiary care facilities and facilities for NICO as well. So we are ask them for repeated checkups. We look for proteinuria, we look for fetal growth in these patients, and we advise the patient about warning signs, that in case she has severe headache, she has vomiting, she has some giddiness, history of convulsion, that may worsen the disease, and she should go to the hospital immediately. So in this, the most important is the role of antihypertensives. Should we give antihypertensives in these patients? As per the obstetric recommendations, we don't give if their blood pressure is around 160 to 100. If it crosses above that, she's a severe degree of hypertension, well, we have to treat them with antihypertensives. And till that time, we just advise them rest. We give them little anxiolytics and monitor them regularly. That's how we deal with these patients.
Thank you. Coming back to cardiology, pregnancy is associated with significant hemodynamic changes which may worsen pre-existing cardiac disorders. What are the cardiac complications following pregnancy?
Pregnancy is a physiological state, but sometimes it can turn out to be a very pathological problem. Usually there are a lot of metabolic and these hemodynamic changes which take place in the pregnancy to feed the fetus and for the growth of the fetus, and that can sometimes turn very bad and it can be pathological. So the problems they can develop is related to what is the hypertension. If this hemodynamic these developments are not, they go beyond certain limit and they go into hypertension at that time because of this volume expansion and weight increase, and this that can lead to hypertension state in pregnancy. Then there are diseases which are already present in this. In younger patients, we see valvular heart disease. In that part in our Southeast Asia is usually aromatic heart disease. And in West we see these days bicuspid valve disease in these patients. Degenerative valvular disease are not seen. So this is about 1% of patients we do have this problem, valvular heart disease. And among the valvular heart disease, there are regurgitant lesions, there are stenotic lesions. It is the stenotic lesions which create problem in this pregnancy. Regurgitant lesions, moderate up to moderate level, even severe regurgitant lesions are not known to cause any problems during pregnancy. It's the stenotic lesion. Even if there is a mild mitral stenosis, if there is a mild aortic stenosis, they carry high risk for pregnancy. And attention, we have to take care of decompensation. Some patients can go into failure. Ideally, what is advised, they can go for a valve replacement, they can go for valve dilatation in case of mitral valve.
Severe PAH?
PAH is less common, but if it is related to valvular heart disease, we have to treat the valvular heart disease. Severe PAH is itself a contraindication. As far as cardiac part is concerned, one is severe PAH, one is the coarctation of the aorta. Then we have to not go for continue the pregnancy because that is a very high risk patient.
Thank you. A related question: gastroesophageal reflux disease and coronary artery disease are both frequent problem in such situations is chest pain. And whenever a clinician is confronted with a patient who has chest pain, we are not sure whether we are dealing with cardiac pain or esophageal pain. So I would start with Professor Kuru, sir. How should we treat this situation? A patient with both disorders.
I think this is an important issue. Esophageal pain the reflex esophageal pain is nearly always heartburn. So that is one. But there is a non-cardiac chest pain because of the esophagus, which may not be necessarily related to heartburn, like heartburn. And that is related to esophageal mucosal sensitivity, which is a very important concept now coming up other than reflex. So you can have non-cardiac chest pain, simulating a cardiac chest pain, not exactly like heartburn. There's another storm which is very common here, that is the laryngopharyngeal reflex disease, that you get a reflex right up to the larynx, and pulmonary symptoms and laryngeal symptoms and pharyngeal symptoms. So that's the spectrum of a reflex disease. From the cardiac point of view, we always, whenever there's a chest pain, we'll always ask a cardiologist to exclude a cardiac disease. And that would be obviously a clerical, it is an effort angina or a chest pain related to effort, having an ECG, having a thallium, and having coronary angio. Obviously, you can exclude a coronary artery disease, but I've seen some of the patients who have neither an esophageal disease and have a coronary angio which is normal, and yet a stress test positive, and that is what probably Dr. Marajin might talk about, small vessel disease which can cause an angina. So then there are conditions where a reflex can cause an anginal syndrome. So that's another thing. So we have to be very aware of all these phenomena. That is heartburn, which is classical reflex, LPR, which is going to the pulmonary and pharyngeal symptoms, then non-cardiac chest pain, which simulates an angina because of esophagus, and classical angina, and which is coronary angio positive, thallium positive. But another syndrome, which is a microvascular disease of the heart, which can also cause angina, which will have a normal coronary. I think Dr. Marajin might like to that.
Some studies which show that reflux of acid into the esophagus produces an actual reduction in coronary blood flow in the absence of a coronary artery.
That is right. There is a complex interaction between reflex esophagitis and coronary artery disease, which has been reported also, that if there is a reflex, that can lead to ischemia also. Reflex, this gastroesophageal reflex can cause ischemia, and the coronary arteries are normal. That is supposed to be due to coronary spasm in these patients. And if we go on another way, the ischemic heart disease, it can cause reflex also. They say that there is this gastroesophageal sphincter comes loose in these patients, and that can lead to this gastroesophageal reflex. So we have to be very cautious in patients who complain of chest pain, even they may complain of belching also. We have to rule out coronary artery disease in these patients by various investigations.
Patient of reflux disease says I have pain in the heart, he may be right.
You may be right. No, actually, most of patients do come with, because they are more afraid of cardiac problem. Any patient who has chest pain, they do first think of cardiac problem, and that has to be ruled out, definitely. He might have esophageal reflex, but we have to rule out.
One related question is that statin usage has increased markedly in the last few years throughout the world as well as here. Now, does statin usage lead to increase in blood sugars, one, or are statins diabetogenic?
There was a very landmark study by Paul Redker that was given in 2008, and at that time the rosuvastatin was introduced into this. That molecule was introduced for treatment of hyperdyslipidemia, I can say. So at that time, what they found that the patients on rosuvastatin do have, some patients did have tendency to develop it was reported at that time, but if we see the mechanism of action, it might be related to all these statins. And if we see the same person is now, Paul Redker, in last week of this New England Journal of Medicine has given the article that statin is the aspirin of this age. So we have, but statin will become the
There are some, the debate is only open because they say statins carry a 14% annual risk of converting the patient into diabetic. So on one hand, we are reducing one risk factor, we are giving him another, which might be more dreadful.
No, what they found is that the patients who develop diabetes usually had some risk factor for developing diabetes, either obese or friendly history of diabetes in these patients.
Really encouraging. Thank you so much. Once again.